Hi, this is Dr. Tom Mosier, and I'm the Chief Medical Officer of HCI VNS Care Services, and I'm going to be talking to you today about advanced care planning, in particular, the IPOST form. So many of you may have heard of the form, but I want to start with where it came from. So historically, we had living will as the primary route for an advance directive. And as I've talked with providers all over the state and even country, I have found congruency when I ask two questions. Have you ever had a patient that's had regrets over their living will, and or have you ever had ambiguity where there was some confusion on how to proceed with that document? And I always get a resounding yes to both, that there is a lot of trouble that the healthcare community and providers have with traditional advance directives, particularly in the form of the living will. And the issues that come to fruition are these. Number one, if the living will is done at all, it's often incomplete and so not really usable. Yet if it's completed, the issue is that oftentimes it's not present. No one knows where it is. They may think it's with the lawyer. They may think it's in a safe at home. They may think it's filed. But regardless, the issue is we don't have it when we need it. If, on the other hand, it's been completed and we actually have it, those living wills that I've seen have often been very ambiguous. They don't exactly speak in a language that healthcare providers know how to interpret it. They're kind of written a little bit in legal speak, in big brushstrokes and broad terms, but they often leave us with a lot of questions. One example of that I ran into when I was in fellowship training in California at Santa Clara Valley Medical Center. And ultimately, I had a patient that was literally in a persistent vegetative state on a ventilator in an ICU for over 5 months. And they ultimately had a very clearly written living will, but it spoke in such ambiguous terms that the family had no idea how to interpret it, even though their loved one had said they wouldn't want to continue living in aggressive medical care if they did not have a good quality of life. Family didn't really know what a good quality of life meant to their loved one. And so ultimately, it was very agonizing for them for that period to try to decide what to do. So if it's not ambiguous, and if it is present, we still have another gap that often happens, and that is during medical emergencies, whether it's in a nursing home or a home setting, sometimes even in the hospital. Oftentimes, at that very moment, there is not a doctor at the bedside. And so ultimately, a living will can only be interpreted by a doctor and then acted upon by that doctor through provider orders. So ultimately, it's not actionable unless there is somebody there to give an order based upon it. And so we have another big gap historically. And then lastly, when it comes down to it, oftentimes there's big gaps in what it addresses. In fact, the clinical scenarios that we encounter day in, day out, the real world scenarios, so to speak, that we encounter, don't really get captured in the big, broad brushstrokes of those historical documents and living wills. So there's a big gap. The intent is good, but the gap in the outcomes is bad. So ultimately, in 1991, Oregon began a movement that has now swept the nation in what's called the POST paradigm. POST stands for Physician Order for Life-Sustaining Treatment. And the idea behind this movement was to empower shared and informed decision-making between patients and their providers that would honor the patient's wishes and achieve true patient-centered outcomes. And ultimately, they captured this in a form and in a process that was very revolutionary and very impactful, and it very quickly began to sweep through other states in the U.S. And ultimately, to date, has now swept the entire nation. As you can see, those states with the darkest pink shading are those with the most mature movement, where they have good penetration throughout all of their healthcare system. Those in the lightest color are those that are just beginning in that journey. And as you can see, Iowa is right up there. We are well on our way to disseminating this form throughout the state, but we still have a ways to go and many opportunities to further capture that uptake. The idea behind the form was this. It captured and empowered and facilitated a detailed conversation whereby a patient and their provider and maybe their families who are present could identify understanding of their illness, could pair that with their values and then their goals of care and their preferences. And the idea is then that it would be captured on that tool, on that form, and then that form would empower a universally actionable, portable, legal tool to honor their wishes and carry them out. Ultimately, it's universally actionable because it actually is signed by the provider and is therefore a provider order. It's just like any other order that a physician or any other provider would give, in that it has to be followed by other healthcare professionals, including EMS or a nurse who's there without a physician present. It's portable because it could be kept on the refrigerator at home or on the back of a bedroom door. It could then be transported to the ER with EMS. It could then be transported to the floor or the ICU and even follow the patient to the post-acute skilled nursing facility or other post-acute setting. And because it was legal, it had the power and the teeth to drive home what was captured on the form. Now, ultimately in Iowa, the PULSE paradigm began in 2008 when a pilot project began in Cedar Rapids. And through that work, an impact came into law in 2012. And so we have this form now. We call it the IPOST. It's really a carbon copy to other PULSE forms, but IPOST stands for Iowa Provider Order for Scope of Treatment. And I say provider because it can be signed and legally actionable based on a physician or a nurse practitioner or even a PA. So here's the form, and as you can see, it's fairly easy to fill out. Just a few check boxes, really. There's a back side, which I'll speak to in a minute. But ultimately, I can draw your attention to the area entitled B. This is the area where we capture what a patient's desires for medical intervention might be, whether it be from one polar area of comfort measures only, meaning I would even want aggressive medical care and transfer to a hospital if comfort couldn't be achieved at home or in a home setting. But I want everything put in the basket of comfort, not longevity of life, versus the polar opposite of full treatment, meaning I would even want aggressive treatments that are a Hail Mary, that might even be uncomfortable if they have a chance at giving me more time to live. To the middle ground, which is I would want medical treatment, and I would want fairly aggressive medical treatment, but to a point. If it's a Hail Mary or it's extremely invasive, I may not want it. Now, there's an opportunity to check these broad categories, but also to give very specific information on the line below, which will help guide providers in emergency situations to the care a patient might want when they can't speak on their own behalf. Now, I can draw your attention to Part A, and what this is saying is, in spite of whichever one of these things that I have advocated for, if my heart stopped or my breathing stopped, I would or would not want cardiopulmonary resuscitation. And really, truly, any one of these is not mutually exclusive from CPR or no CPR. And then lastly, in the event that because of my illness, I'm not able to eat and drink, and I may need artificial nutrition and hydration, I would for sure want it, even long term, if it kept me alive. I would never want it in any circumstance. Or I might want a defined trial period of artificial nutrition and hydration whereby benefits and risks can be better teased out for me. So ultimately, these are the medical sections that give incredible poignancy and power to what a patient's wishes might be and direction to the provider. But then down below is an opportunity for more information about who are the medical surrogates who participated in the form, who is the provider who signed off, what is their contact number if you have questions or need to pull them into things, And then on the back of the form is an opportunity for the power of attorney for healthcare or the surrogate decision maker's name, address, phone number, so that they can be reached in an emergency, which is often a huge gap that EMS runs into, or even nursing homes run into when they don't know who to call when a patient begins to decline and cannot speak on their own behalf. So ultimately, it's a very powerful tool, as you can see. But it's not unlike any other tool. So I am a woodworker, as an example, and I have a shop full of very specialized power equipment and tools. And ultimately, when I use my tools, I can build furniture, I can do amazing things and have amazing impact and outcome. But I think you'd all agree that if my 12-year-old son, Tommy, walked into my shop without me there to guide him or teach him, he could not only make a mess, but he could even hurt himself and cause great harm with those tools used in the wrong way. And I would argue that this form is no different, that this form, if taken lightly, if just used in a 5-minute checkbox where we hand it out to patients and say, hey, could you fill this out before coming into clinic today, could be catastrophic. And I'm going to illustrate why in just a minute. I would argue with you this. When we buy a house, we think about this decision and research this decision and look at houses all over because it's a huge decision. We know it's going to have huge financial ramifications in our life for at least the next 30 years. If it happens to be a lemon of a house, it's going to be even more painful because it could become a money pit. We also know that this purchase decision can impact our families in very powerful ways, both in the school systems we're in the neighborhood we're in, and it can really have an impact on our whole family and our whole life. So it's a huge decision. Likewise, maybe slightly lesser in gravity would be buying a car, but no one buys a car lightly. It's again a very big decision that can have some big ramifications in our life if we don't put some thought into it. But I would argue this, there is no decision more sacred or that has the bigger potential to impact positively or negatively than the healthcare decisions we make, particularly when it comes to crisis situations and emergencies where a patient cannot speak on their own behalf. And ultimately, therefore, this form deserves just as much attention to detail as any of those former decisions. So I want to drive this home a little bit. I want you to look at this slide and tell me, would you prefer, if I had to get you from point A to point B, would you prefer to drive on a road that looks like this and this, or would you prefer to drive on a road that looks like this, or lastly this? Now think about that for a minute. I'm going to tell you that in the numerous times I've given this before, numerous audiences, I've never once had a single person choose the later three pictures. It's always 100% unanimous that everyone would prefer to drive on the former two roads, those scenic routes. Yet, I'm now going to add some context because, see, I know your preferences. And so now if there was a checkbox on the IPOST, I could check it. And we would know for anybody who had to make a decision for you that if you had an emergency, what you would do. So this is the situation. Your father, who you love dearly, who lives in East Lansing, Michigan, just got into a very serious car accident. And you were contacted and informed that he is not expected to live more than hours to days. You're very distraught and you need to get to Michigan. So you're going to fall back on the form that you filled out with me. And I went ahead and got you a bus ticket because I don't want you traveling and driving when you're so distraught. And I've routed you on one of my favorite drives through Wisconsin, which is gorgeous. I'm pretty sure some of those pictures came from this area, through Upper Peninsula, Michigan, another very beautiful and scenic area to drive through. Across the Mackinac Bridge, an amazing marvel, a 5-mile suspension bridge. Through northern Michigan, which is just wooded and beautiful with lakes everywhere, down to East Lansing. Now, if you're lucky and you don't stop at all for eating or bathroom breaks, you'll make it in 15 hours. And I certainly could have routed you through this direction but I'm pretty sure that Hammond, Indiana and Gary, Indiana is where some of those pictures of the later 3 photos came from. So I'm positive, based on your preferences and preferences voiced by so many, that would not be the way to go. So my question for you is this: are you happy with my decision, or do you have some regrets about that? And in all of those that have heard this talk that have come before you, I will tell you, there has also been 100% congruency that nobody is happy with that decision. And so the question comes, why? Why, if it was so easy to make the decision in the first place, if there was 100% unanimous decision that the scenic routes were the preference, is everybody so unhappy with this decision? And I would submit to you this, that ultimately what changed is I added context to the situation that gave you the ability to bring in your values. And your values then helped guide a better decision for you than the one that came at face value with just a preference. And I would argue that medical decisions are no different. When we ask a patient in the ER, if your heart were to stop, would you want me to restart it? You'd have to be stupid to say no, right? Who would ever not want their heart started if it stopped? But if you give context about the gravity of the illness, about the small potential for help and the large potential for harm, about the potential for not having good quality of life downstream, or maybe never having dependence, or maybe never making it out of the hospital, people may give you a different answer. Ultimately, medical decisions that are made with understanding of a patient's values at the same time that the patient and family have knowledge and details about the context of their illness and their situation, then and only then does the potential of regret go down. Without that, however, you run the risk of having somebody fill out a superficial form that actually can perpetrate harm and regret. This tool is a very, very powerful tool. It's the best tool that has ever come, and probably the best tool that ever will come. It's actionable, it's specific, it really helps facilitate a very important conversation. I would encourage you, if you've never heard of this, to go look for it, to ask your providers, to ask your hospital systems. I would encourage you to ask to fill it out. But I would also encourage you to make sure that you're guided through it in a way that pairs it with an accurate understanding of the context of your situation and your health. And if you're a provider, I would encourage you to please spend time talking to people about their illness and what you expect, and pair that with their goals and values. Because when that is done, this tool can have an impact that transcends anything that has come before it. Thank you so much for your attention, and this concludes this talk. Have a wonderful day.